also watch that, later on. We'll put it on the website. Our website should be ready next week, and then I'll put it all the groups on there for everybody to be able to see.
Okay.
Hi, Andrew, are you well?
Yes, I'm very well. Can you hear me? Sorry.
Yes, I can. Yeah. And Janet, are you
okay?
Sorry,
yeah, I'm good, thanks. Thank you.
Okay.
Yeah, all is well.
That's good. We had about 3 apologies. I'm going to just wait a minute or so to see if some more people arrive, and then Tara will start speaking. We've just been speaking. Tara has been is a dietitian and nutritionist, and has been really a speaker all over the world in the last few years. She's been working with NETS patients for 12 years now. So that's quite a long experience that she has. And we were talking about the possibility of actually getting her to speak to some of our dietitians here in South Africa, and to perhaps do some training for them. So that's also very exciting. So we're really looking forward to that possibility. So we'll try and see if we can get that organized.
Sorry, you came very highly recommended by Ronnie.
Yeah, absolutely. Yeah, you, Ronnie's like star.
He spoke you up, I'll tell you what. That's good.
So Ronnie's not joining, because I thought maybe Ronnie would join.
He said he'll try. He'll try. But I think he's a busy man. You know what he has to do just with that social media is hectic enough.
I know. It's 24 hours a day probably.
Yeah, I'm sure. I think it's I'm sorry that we're so few, but in any case, let's get going. I'm going to make you a host as well, Tara.
Okay.
So that you can how do I do that? I think I just press on the button more, make a host. Then you can share easily.
Okay.
There you go. So, yeah, thank you very much for being willing to be with us tonight. And we really look forward to learning from you, and look forward to furthering this collaboration even further, and try and also include some of our African, other people in Africa, Zimbabwe, and so on. So the floor is yours.
Lovely. Thank you. Can you see?
Yeah, perfect.
Thank you. Yeah, I'm just going to move myself to the side. Or maybe I'll just click off it actually. Okay, lovely. So I've just put some slides together, and it doesn't cover everything, but it will cover some of the main questions that you may have had. And I think we've got loads of time afterwards for questions anyway, so you feel free to ask whatever you want. But the main presentation will be about digestive problems, and a little bit on deficiencies as well. So, as you'll know, the problems that exist with neuroendocrine cancer can exist because of the cancer itself and where it's situated, but also the treatment. And sometimes the treatment is the main problem, actually. And these can lead to a variety of complex nutritional problems, and often problems that people really can't get to the bottom of on their own, or just with a doctor. So that's where the dietitian comes in. So there are multiple causes of digestive problems. So as I said, the cancer itself can produce hormones and peptides. So if it's an active functioning tumour, it will produce these things that go into the blood and cause these horrible symptoms. Or you can have the tumour actually obstructing and blocking an area, so a bowel obstruction, for example. Then you can have the treatment itself. So, for example, surgery, you can remove a part of the intestine or the stomach, and this can decrease the ability to absorb food. In terms of absorption, we call it malabsorption, where you can't absorb properly, and some of the medications like somatostatin analogues, so the lanreotide and octreotide injections that you may get 3 weekly, 4 weekly, these can lead to malabsorption because they affect the pancreas, so I'll be talking about that. And then there's other therapies, so you may have chemotherapy, for example, and some chemotherapies can cause diarrhea. Some can inflame the stomach and cause nausea or vomiting. So lots of different issues to deal with, depending on where your cancer is, where it's spread, and what kind of treatment you're on. And of course, your treatment may change. And so over the years, a dietitian will be involved, hopefully involved. So we see people through the whole cancer journey. So first of all, because it's always the most popular topic, is the topic of loose stools. And actually, when patients are diagnosed and maybe they have a functioning tumour, they always presume that every time they have a loose stool, that it's the hormones or the peptides that are causing this problem. For example, people will assume it's carcinoid syndrome, even if they're on treatment, which is probably controlling the carcinoid syndrome. A loose stool isn't always a result of a functioning tumour. It's often something entirely different. And that's where our role comes in, really. And we're like an investigator. We're trying to find out what exactly is wrong, because often the culprit isn't what even the doctors may think it is. So often the culprit is pancreatic exocrine insufficiency. So this is where the pancreas is not sufficiently producing enzymes or no enzymes at all. And these enzymes normally break down food. And if you're not producing enough of them, then you're not going to break down food and you get this steatorrhea. Sometimes it's not obvious. It can just be malabsorbing food chronically for a number of months to years, and you may end up losing weight or becoming fat soluble vitamin deficient, for example. So that's one kind of loose stool, the steatorrhea. And then there's things like pellagra, and this is the side effect. It's the obvious symptoms which come from vitamin B3 deficiency. And one of the symptoms that you see, sorry, I've got a dog drinking at the moment, flapping her ears. One of the things that you can see is diarrhea as a result of pellagra. There's things like bile acid malabsorption, and this is a slightly different type of loose stool. It can be acidic, it can be fatty as well. But it's that kind of, when it's severe, it can be a burning kind of stool, and an irritant when it comes out as well. So slightly different to the kind of steatorrhea that wouldn't cause that. Then there's things like small intestinal bacterial overgrowth. So I will talk about that in more detail, but it's the overgrowth of bacteria in the small intestine caused by something like surgery, can be medication or investigations like a colonoscopy, where you're transferring bacteria from the large bowel into the small bowel. But I think it's probably most commonly found after surgery, where there's inflammation. We can get overflow diarrhea, so where you're constipated, and then at the point where the constipation is ending, then you can get a lot of diarrhea that follows, especially if you use enemas or a load of laxatives, or if you're in obstruction and the obstruction clears. Things like hyperthyroidism, so overactive thyroid, can cause diarrhea. Inflammatory bowel disease and IBS and celiac disease, these can all coexist. So you might be so unlucky that you get one of those other things as well. And that's why we always do repeat colonoscopies and gastroscopies, and look at the small intestine as well with a camera, and biopsy things if we need. And then obviously there's things like food poisoning, you know, that still happens, especially if you're on something like a proton pump inhibitor for reducing stomach acid. So your stomach is less able to defend itself against pathogens. Food poisoning is slightly more likely to occur if you don't have so much acid. So on to the first main subject then, so pancreatic exocrine insufficiency. So where we're not breaking down fat, carbohydrate and protein. This can be the result from a pancreatic cancer, so a neuroendocrine tumour or an adenocarcinoma, or where you've had the actual surgery to remove part of the pancreas, the use of somatostatin analogues, and even things like diabetes where the pancreas is inflamed enough, or pancreatitis, so where the pancreas is fully inflamed. It can cause fat-soluble vitamin deficiency. So vitamin A, D, E and K can become low if you're not absorbing the fat in your food. And so what we do is prescribe pancreatic enzyme replacement therapy, so shortened to PERT. And this contains a pig version of our own enzymes. So it's porcine, lipase, protease and amylase, and they break down exactly like our enzymes will do. You can test whether you've got this problem going on using fecal elastase testing, but one of the studies that was done in Cardiff in Wales suggested that it probably wasn't a good idea and overly accurate, especially if someone's already on enzymes. It may be just worth starting enzymes anyway if you can, the prescribed ones, just because if you've suddenly started a somatostatin analogue or you've had surgery, we know you're probably going to get this steatorrhea anyway. And is it really worth testing? It probably isn't if we think the culprit is pancreatic exocrine insufficiency. So often we just start people and the problem will clear up once they're on the right dose. So there's different types of PERT. So the only medically tested ones are the pork, so the porcine origin, and they're gastro-resistant. So they don't start breaking down in the stomach. They start breaking down when they're past the stomach and they're in the duodenum.
in our internet.
So there's vegan or vegetarian. The vegan and vegetarian supplements are sold as alternatives on things like Amazon or on the internet, but actually they're not medically tested. They're probably low doses of lipase, which is how we measure them, and they're not gastro-resistant. So we don't recommend their use unless we're really desperate and someone isn't willing to try the pork origin. Obviously there's cultural and ethical, I guess, requirements in some patients, and so we try and work with you, but we can't guarantee the other ones that aren't medically tested will work at all. Okay, so in terms of dosing, the dosing should always be under the care of the dietitian. So an HPB dietitian or a gastro dietitian or an oncology dietitian. And the main brand worldwide, I think, is still Creon. There are lots of other brands, but this tends to be the cheaper one. So the dose, if you're using the version that comes from the US, is 24,000 units. Of lipase. If it's the European one, it's 25,000 units of lipase. And we start with one of those capsules per snack and then 2 per meal. That's not usually ever enough, so we titrate it up. So we just increase it by 1 capsule. And the general rule is the more fat that's in your meal, the more of the enzymes that you have to have. There is a maximum, so some people take too many, and that can injure the bowel and stop it working and kind of kill off the cells. So we don't want that to happen, but it's basically 10,000 units of lipase per kilogram of body weight. So if you're 70 kilos, that would be 700,000 units of lipase per day. It's quite hard to get to that, but some people do take a lot, and perhaps you don't need to take that many. Perhaps if you've still got loose stools, then it might be something else that's wrong. And you can get coexisting loose stools of various types all at the same time. So in terms of timing, taking the enzymes, if you're on them, these prescribed enzymes aren't as good as your own pancreatic enzymes. Therefore, they really need as much help as possible to work as best as they can. So what we say is take half the dose with your first mouthful of food, and then the other half halfway through the meal, not after. That's too late. So the capsules have to start breaking down in order to start mixing with the food that's come out of your stomach, and then they start breaking down and munching on your food. If you're then having a dessert, then you would have another 1 or 2, depending how much fat is in that dessert. And I know I've talked about fat and the need to have the enzymes with the more fat, but we're also trying to break down the carbohydrate. We're also trying to break down the protein. So yes, we measure it based on the fat in your meal, but we also need to break down those other nutrients. If you're not getting enough protein, you're not going to look after your muscles as well. And if you're not getting enough carbohydrate, you're not going to have the energy either. So we need all of those 3 nutrients. And if it's not working, and you're still getting steatorrhea, possibly there's something else going on as well. There's another cause of loose stools, but check that you're taking it correctly. The dietitian, if you're seeing one, should do this, and it's basically first mouthful, glass of water, start eating, and then halfway through take the other half of the dose. If you're going up to your maximum dose, you can't go any higher, again, maybe there's something else going wrong. Another diagnosis maybe that needs to be looked into. I mentioned PPIs, so the proton pump inhibitors, which are the ones that reduce stomach acid. That is in the recommendations of what to do when your enzymes might not be working as well as they can. So if your stomach and your duodenum are too acidic, then reducing the acidity might help the enzymes break down, and the capsule will release the enzymes into your food a lot easier. So we try one of those drugs. And then the correct timing of taking that PPI. So I always say first thing in the morning, before you've eaten, you need to have a lower amount of acid, then wait half an hour, have your Creon or other enzyme brand, and then eat. So you've got to time everything correctly as well. So on to different subjects. So different type of loose stools caused by pellagra. So pellagra is the effect of vitamin B3, so niacin deficiency. And this is what we see generally only in carcinoid syndrome. So active functioning tumours which are producing lots of serotonin. And there's a couple of studies that have been done looking at newly diagnosed patients. So between 28 and 45% of patients with the serotonin production with visible carcinoid syndrome, and sometimes no visible flushing or diarrhea at all, have actually been tested as low in niacin, and some of them are visually diagnosed with pellagra. And basically there's not much guidance within the neuroendocrine tumour world on this at all. We are writing guidelines at the moment to improve things, but the World Health Organization are the only people really that have produced anything on this, and actually most of this has come from the African population, and they advise that if you have got someone with visual symptoms of pellagra, then the treatment is 300 milligrams per day for a month in split doses throughout the day. You can get flushing when you take this niacin as nicotinamide, or niacinamide or niacinic acid. So they recommend that as a treatment, and I think we're writing guidelines at the moment, but I recommend about 100 milligrams per day if you have a serotonin producing tumour, whether it's active at the time or has been active in the past. Prevention, I would say, is something around 100 milligrams a day. So what we're looking for, signs of pellagra in adults, we're looking at changes to the skin. So often in Facebook groups, we've got people who are showing different rashes and things on their arms. It really needs to be looked at by a specialist, a dermatologist, you know, ask whether you think this could be pellagra, because the skin can be affected. We're looking at problems with the mouth. So you can have swelling in various areas of the tongue and the mouth. When we're thinking about diarrhea, it could be a cause of, it could have come from this pellagra diagnosis, and it tends to be the watery kind of diarrhea. And of course, there's carcinoid syndrome diarrhea the same time, so it's very difficult to really know what's causing what, and therefore you need to look at other symptoms like the skin and the central nervous system. So that's often something that I talk to people about, because this niacin deficiency will eventually cause dementia. So forgetfulness, are you forgetting, you know, are you forgetting appointments, or you know, it tends to be kind of, you know, not always obvious, but if you think back over the past few years, you know, has your memory got worse? So have a chat to the doctors about that if you think that it has, and you're not already taking a nicotinamide or other supplement containing niacin. So different type of loose stool again, so the bile acid one, so the acidic diarrhea. And this is broken up into 3 types of bile acid malabsorption. So type 1 is where there's a problem in this part of the small intestine, so the very last bit of the intestine where it joins the large bowel. And this is where reabsorption of these bile salts that have come from the liver takes place, okay? And if there's a problem in that area, the bile salts rush into the large bowel and cause a very urgent need to go to the toilet, and often, as I said, it's acidic. So you can get inflammation of that area. You can have inflammation because there's a tumour, or because the tumour was cut out of that area, like an extended right hemicolectomy might cause that. But a sufficient amount of the ileum, which is that last bit of the small bowel, has to have been removed to get this problem generally. You can have obviously other cancers, other things like Crohn's disease that affect that area as well. And then there's the type 2, so where there is no real cause and no one really knows why it's happened, and that can that's known as primary bile acid malabsorption. Then there's type 3, so that can result from other diseases that are further up. So gallbladder diseases, gallbladder removal, celiac disease, chronic pancreatitis, and things like radiotherapy that's maybe affected that area and made it swollen. Or things like small intestinal bacterial overgrowth, which I'll talk about in a minute. So how do we treat this acidic diarrhea? So we use bile acid sequestrants, so things like Questran. There's other tablets available as well normally, which might be more palatable. But as dietitians, if those things aren't working on their own, then we sometimes reluctantly have to go to a low-fat diet, and that's because the more fat that you have in this condition, the worse it will get. However, when I say reluctantly, we're reluctant if people are already underweight and they really need those calories from the fat. So sometimes we have to balance what is more important, and try and work with the patient. And obviously it might not just be a bile acid malabsorption issue. You might need the enzymes, you might need treatment for other things. And then we need to look at the fat-soluble vitamins. So like in steatorrhea, especially if you have steatorrhea and this acidic diarrhea at the same time, we need to monitor fat-soluble vitamins, vitamin A, D, E, and K1, if that test is available. So on to small intestinal bacterial overgrowth. So basically you can have overgrowth of the bacteria which produce methane, and those patients often have constipation and wind, not loose stools. The most common type of overgrowth is the hydrogen producers. So we call them hydrogen exhalers. And this is because the test for bacterial overgrowth is a breath test. So you're exhaling more hydrogen in response to taking one of the drinks that you're given at the test. So we often use a lactulose, which is a laxative, but it's also something that the bacteria in your digestive system will munch away and produce more hydrogen or methane when they're munching it away, and this is exhaled in your breath. So we call you hydrogen exhalers, and these patients have lots of diarrhea, and often that can be obvious after surgery, as I said earlier. There's no definitive dietary prevention or treatment. We often do a lot of trial and error. The main treatment is rifaximin or rifaximin and neomycin antibiotics. So they're poorly absorbed antibiotics which tend to work well, and sometimes if they haven't worked well in the past and someone's having another trial of treatment, then we'll maybe use a low FODMAP diet or a probiotic alongside the antibiotic. Some centres have tried fecal transplant, so where you're transferring fecal matter from one patient to another via a long tube that goes down past your mouth so you don't taste anything. It's transplanted into your small intestine, and it brings a whole load of other bacteria species which we need, because we need a very complex mix of bacteria to have a healthy small bowel. Or large bowel, where most of the bacteria should be, but we have a small amount in the small bowel, and the idea is that we push out the bacteria that are overgrowing. However, this hasn't been shown to have any long-term effect, and people tend to go through treatment over and over again. If you have got a positive diagnosis of the breath test, we also look at vitamins and iron, there's B vitamins, and depending on how long you've had the symptoms, if you've been malabsorbing for quite a long time, then we'll run a screen of vitamins and minerals. So then the syndromic diarrhea. So as I said, there's carcinoid syndrome, but there's lots of other syndromes as well, and which are more rare. But for example, the VIP-omas, so the VIP-omas, which produce really vast amounts of watery diarrhea throughout the day, every day, until it's controlled. So we try and get patients on a treatment that works to control this diarrhea. So you may have, if you've read around the subject a little bit, you may have heard about dietary triggers and foods that cause this carcinoid syndrome diarrhea. So we have to be careful that we are talking about the trigger of this particular type of loose stool. It's not a well-studied area in terms of diet. It may be well studied now in terms of pharmaceuticals, but there hasn't been any funding for us to do really any work in terms of triggers. There was some work done about 15 years ago, but it was never published. So really we need some funding in this area to look into it more. We have lots of theories and hypotheses, but we need proper work to be done on this. So in terms of my experience, we know that this carcinoid syndrome diarrhea continues with or without food. So often people starve themselves so they can go out the next day. It may help, but it won't stop it completely. You can try and take lots of loperamide and things like that, but it's still very difficult. And we want you to continue eating. So one of the things that we've looked at, and the idea really came from dietitians in the US, are these vasoactive amines that are contained within foods and drinks, and they can trigger symptoms in a small proportion of people with a functioning tumour, so a serotonin producing tumour that has the potential to cause carcinoid syndrome. And so when we look at the evidence, the high vasoactive amine foods are the foods and drinks on this list, basically. So anything that's aged generally, cured, whether it's fish or meat, anything that's been in your fridge for a long time. It doesn't have to go moldy, but for example, some people get a flush and diarrhea because they've had some milk. And milk really shouldn't do that if it's fresh, but if you age a food and then the proteins start to break down, they release these vasoactive amines, and you'll notice that some of these foods are the things that migraine sufferers have an issue with. So yes, they contain things like histamine and tyramine and things like that. But there's various vasoactive amines, and this list contains the ones that are highest in most of them. Often people talk about, green tea. I drink green tea because it's healthy, isn't it? But it can apparently be an issue. So you've just got to be a bit careful, and anything really that contains caffeine can be an issue as well. When we're looking at food triggers, that list is not a list to exclude everything. Often people see the list and think, right, that's my diet now. Well, actually, no. If you're under the care of a dietitian, we ask you to do a food and symptom diary. So write down what you've eaten, how much, and then in the next hour or so, have you reacted? Have you flushed? You might be on a treatment that controls your flushing, so that's great. You can continue to eat the food. Have you had diarrhea? If that's no, then great, you can continue. There's no harm being done. If you do flush or have diarrhea within an hour, is it the vasoactive amines, or is it that you're not taking enough enzymes? In the initial research that was done in the US, a lot of the fatty foods were kind of misblamed for causing carcinoid syndrome, but actually fat won't cause carcinoid syndrome. It will cause problems if you're not on enzymes and you're not on enough enzymes. So we've got to have a look at the vasoactive amine content of the food and then any symptoms that follow. So if we're looking at things like this, the champagne and the wine and things like that, is it the alcohol? Have you always had that flush? Because alcohol can cause the flushing. You may have issues with the additives in wine. So the sulfites, which are used as a preservative, they can cause the flush. So they're a different topic to the vasoactive amines. So we're really investigating which part of the drink or part of the food is causing an issue. if you've really got bad carcinoid syndrome and your treatment is not working, and even whether you're having food triggers and eliminating them or not, you always need to use an electrolyte replacement. So these are the sachets, which you all know about. Over here it's called Diarylyte, but it's the electrolyte salts plus a sugar like glucose, and it's generally got flavouring, and you mix it with water. You can have sports drinks and things like that, but you've got to be careful that they're the right ones. Some of them are a bit useless if they haven't got the right concentration of electrolytes. So on to the other side of things, the more slower transit of the bowel, so constipation. That can be a side effect of some treatments. So when we did a survey about 4 years ago now, I think, we found that actually the biggest problem that people had after starting a somatostatin analog was constipation, or feeling like they hadn't gone to the toilet enough. So they'd been, but they still wanted to go back. And it can come from obviously too many laxatives, but even some people with chemotherapy, they can get this constipation. So constipation is generally where you don't go to the toilet at all, or some definitions of constipation are just once a day. So depending on what definition we go with it, but it's generally a slow bowel transit, and that's not good for our bowel. We need food to move through, our drugs to move through, whatever we're taking, and in order to do that, we've got to have enough fibre. If you're having a very high fibre diet, we need loads of fluid to go with that fibre, so your stools aren't too dry. We need to increase exercise. As I mentioned with small intestinal bacterial overgrowth, methane exhalers can be more constipation predominant. So is it that you've got this overgrowth, or is it another cause? We change the diet around, so depending on how much fibre or not someone's having, fluid and exercise, will change those kind of things around. But we can also add in supplements, fibre supplements or probiotics and those kind of things. Increase fluid and get people moving. It doesn't have to be vigorous exercise, but you've got to be mobile to some degree. And then often things that go with loose stools and constipation is gas and wind. It's a really common problem. So you might be burping it up, you might be losing wind going down, or it might be trapped, which is really painful. And I've suffered with trapped wind before, and it's a horrible pain that goes through your back, I know. You've got to think whether are you swallowing too much gas? Are you drinking fizzy drinks? Have you got, you know, are you swallowing air when you eat because you're eating too quickly, or are you using chewing gum, those kind of things? But of course, the wind and the gas can be produced by your food and by the bacteria that are munching on the food. Really, it's a good idea. It's a good idea to get a dietitian assessment if you can, and we'll look at whether these high FODMAP foods. So these are the foods that we use in IBS treatment, and exclude them. They're the fermentable carbohydrates, basically. There's things like wheat that could be a culprit. There's fructose and lactose. Some of the pancreatic enzymes can cause wind. Are you eating too quickly? Are you having lots of brassica veg, so the cauliflower and cabbage and all that, which cause wind in most people? Is it a garlic or an onion problem? And so we'll change the diet accordingly, but there are other things like peppermint tea, which might cause a little bit of relief, but there's charcoal tablets and things like that, which can help, or sometimes people try probiotics, and that might help in some circumstances if we know where the problem is. And I thought I'd mention bowel surgery because it is often a problem that people have continued issues after bowel surgery and their care hasn't been great following, and they've not been able to see a dietitian because it's just not been part of the plan, and they're discharged from the surgeon and kind of expected to get on with things on their own. And it's just important to know that intestinal adaptation can take 2 years. So what I mean by that is when you've had something chopped out, it will take your bowel up to 2 years. It's not usually 2 years, but it can take up to 2 years to reduce inflammation, to heal and absorb and allow food to go through normally at a normal speed. And allow, you know, how you feel to kind of settle down and have a normal amount of bowel movements per day. So most people can tolerate normal fibre intakes after a couple of months. So you might have a right hemicolectomy and you're told to go on a low fibre diet or a low residue, what we used to call it. That's basically a plain diet. And often people continue on that diet forever. And often I meet people several years down the line and they're still on it, and they don't need to be unless they're at risk of obstruction. So if they've then got scar tissue, desmoplasia, which is this white tissue that wraps around the intestines, or they've got the tumour wasn't resected or resected enough, then you can have this obstruction. So if everything's clear, your colonoscopy has shown that things are good, then you don't need to change the amount of fibre or the form that the fibre is in. So by that, I mean, imagine a piece of broccoli, you've chewed it a bit and it gets down into your bowel and it's still in bits. If we're changing the form and the consistency of that broccoli before we ate it, we would maybe use a food processor and make it into a soup, and we can have no issues when it goes down because it won't get stuck, as long as you're not having too much of that food, too much fibre all at the same time. So there are other conditions which can cause blockages as well. So things like diverticulitis can flare up and you get these pockets of food that cause an issue and pain, or other types of bowel disease. So, you know, you can get 2 different types of cancer, or you can have inflammation from ulcers and things like that. So it's just important to, you know, speak with the doctors about your symptoms as much as you can. That's it for the topics. I know there'll be questions that maybe people have. If I stop sharing my screen now, let me just and if there's any questions, I think, yeah, I can see everyone now, I think.
And so the one question was, what is the test for enzyme deficiency?
So there's the fecal elastase testing.
You ask your doctor about that or the dietitian?
Both. The doctor will probably be the one that orders the test. So that's fecal elastase testing. If you are not sure what kind of loose stool that you've got. So if you're not really sure whether it's fatty, but you think it might be, and you have got reason to believe that it could be, you could take a fecal elastase test. So that's looking at a stool sample. But most patients, if they've started, for example, a somatostatin analog, or they've had pancreatic surgery, or they've got a tumour in a place which obstructs those enzymes, we would think, okay, well, you've probably got pancreatic exocrine insufficiency. So shall we just start the enzymes and get on with treatment? But it's, yeah, I guess everywhere has their own way. Other people might disagree with that and want a test to confirm it. So it's really what happens at your unit or hospital.
Did you guys find that you were asked about the enzymes, or did you get guidance around that, Rahima?
Yeah, I'm on the Creon, so I've got
Okay.
the 25,000 or 24,000 units that I have to take per meal. I've also got the smaller units, the 10,000 for snacks. How do I know when I can get off it? I'm hoping.
Sorry, say that again.
Can you get off it?
Yeah, probably also to get the test, eh?
So if you're on somatostatin analogues, you'll probably need the enzymes for life.
Okay.
Okay. Because the problem doesn't just disappear, unfortunately. And with the 10,000 units, they're only to be given to children. Okay. So when we have a normal meal, so say I go and eat something now, my own pancreas, as long as it's healthy, hopefully it is, will produce about 1 million enzymes. Okay. So that 1 million enzymes is nothing. Well, 10,000 units is nothing compared. So we don't use them in adults. They're only a pediatric dose. So if you're on the 24,000s, most people will need 3 times 24 per main meal. And then if they have dessert, then they'll need more.
That's quite a lot, eh? Yeah.
Mm.
And do those enzymes have side effects? Obviously, they must have. Or not?
They can cause wind.
Yeah.
They can cause wind. They can cause constipation. They're the most common ones. If you open the capsules up, they can burn the mouth, and you can have an itchy throat. But you shouldn't open them up unless you put them into orange juice. So they can only go into an acidic drink or something, or they start digesting before you've taken it, and then
they don't work.
Late.
Yeah, then it's too late. Okay.
When do they cause constipation?
Sorry?
When do they cause constipation?
Maybe if you've taken too many.
Okay.
Yeah.
Sure.
I've only been told to take 1 to 2 per meal.
So what you need to do, if you're happy with, if you're not having any symptoms, so if your bowel movements are 1, 2, 3 times a day of normal consistency, normal colour, and you're happy with that, just track your weight, because the side effect of not absorbing food is obviously weight loss. And if you can get your vitamins tested, so the A, D, E and K1, you can see whether you're absorbing the fat as well. So they're kind of telltale signs that you're doing things right. Okay.
Yeah. I've been losing weight, but I've steadily gained it. I'm back on my normal weight now.
Okay.
So I'm assuming I'm doing things right, but now for the last month, I've become constipated a lot. So some days I'm fine, but then some days it's every 2 to 3 days. So it's crazy. I'm not sure what's causing it. Maybe too little fluid, as you said, compared to fiber, because I've been increasing my fiber now to see if that's going to help. But I haven't increased my fluid intake, so maybe I should do that as well.
Yeah, fibre and fluid go side by side, so keeping active, often walking, going for a walk after a meal and that kind of thing can help just move things through.
Any rule of thumb on sorry, Tora, I beg your pardon. Carry on.
I was just going to say that, so like a high fibre cereal for breakfast with a live yogurt, a probiotic yogurt or something like that tends to work really well. But the other thing that I didn't mention is linseeds or flaxseed. same thing. And just like a live yogurt, as long as you're not on chemotherapy, live yogurt with some flax seeds on your spoon as well. That's our main treatment for constipation. So
that's an easy one. Yeah.
Yes, yeah. I forgot about that. I did that once and then I forgot. And I used to give it to my mom for that.
Oh, okay. Yeah.
Yeah, that's a good reminder there. You wanted to ask something, Andrew?
I had a couple of questions. One was there any sort of rule of thumb in terms of how much liquid you should drink a day? I mean, it's a difficult one. I asked the question because I've been currently on PRRT, and I'm on a sort of third treatment this year. And it's not being done in hospital. And the problem there is that there is, in hospital, when you're in there, they tend to give you saline on a drip virtually 24 hours a day.
Mm-hmm.
So the difficulty is that I find that I'm not drinking enough, and I was sort of advised to take anything from 2 to 3 liters of water a day. But just generally, and in terms of dietary sort of situations, is there some sort of rule of thumb? Would you sort of say that we should all be drinking 2 liters of water a day, or?
So under is it 60 or 65? I think it's under 60. I haven't got my book with me, but it's 35 mils per kilo of your body weight, and then it drops 60 or 65. It then drops down to 30 mils per kilo, but that's without sweating for any kind. So without exercise and without being in a hot place.
Yep.
Or having a fever. So generally most people will need under 3 litres a day. Obviously if you're doing lots of endurance, going for a bike ride, that kind of thing, you'd need probably double in a hot country anyway. So is it quite hot where you are now?
It's starting to become autumn, but yeah, but it is, the days can be hot, and then the mornings, early mornings and evenings are chilly, but it gets, up to 32 sometimes.
Okay.
But it's slowly cooling down now towards July, May, June, yeah.
Yeah, okay.
But in summer, it's hot.
Mm.
There are 2 other questions. One was, I had my gallbladder removed following sort of liver resections. Is there any sort of concern that one would have with the gallbladder in terms of nutrition? Should we be looking at anything particularly? I mean, if somebody said, I've had my gallbladder removed, would you sort of suggest any sort of specific sort of areas of testing? Do you know what I'm trying to say from a nutritional point of view? Are you short? You could well be short of this or anything like that.
So basically, when you have the gallbladder removed, there's no storage for the bile that breaks down a lot of the fattiness in your food. So you can get that bile acid malabsorption. So it's the type where when you watch this video back, there's the list of different types of bile acid malabsorption, and it's quite a tricky one. You can take the Questran and things like that, but it's sometimes about how much you eat or how much fatty food that you eat all at once. So you have to generally be a bit more careful. Often they used to say just avoid fatty food, but that's not really realistic, especially if you're trying to hold your weight. But speak to the doctors about it if you are getting any symptoms.
A degree of constipation, a degree of sort of gas formation sometimes, which can be a bit
uncomfortable.
Uncomfortable, but it's normally reasonably regular. But from time to time, I get a sort of sense that feeling that you mentioned of not getting everything out, that sort of thing. And that is what I'm having. That may well be that bile thing that you're talking about, and it could be the methane exhalation thing. I don't know.
Yeah, I mean, if it's the methane, it's all the time. It's severe bloating and constipation all the time. It doesn't go away until it's treated. But with the gallbladder, you just maybe need to be a bit more careful about the size of the meals and how much fat, especially that
Yes,
it
and smaller
contains.
meals more often, sort of thing.
Yeah,
And oftentimes the guideline of small meals more often is like, or they say that, but to actually do it is very difficult because we're kind of in a culture of 3 meals a day. You know, you're not in a culture of 6 or 8 meals a day, and it becomes quite tricky to have, like, you know, fit that in, and patients really struggle with that, very much so. Yeah.
Yeah,
And
it can be. It becomes a full-time job
yeah,
sometimes.
exactly. It becomes a bit of an obsession. The one thing that, you know, for me is also, what do we do in terms of patients that are not like us, have the privilege of medical aids and stuff, where nutrition is, you can't buy live yogurt and you know, because you hardly have a fridge or whatever. So you know, in the guidelines that's being prepared, are we also looking at poverty kind of guidelines, you know, for patients coming from a poverty kind of environment? Because I think that is a huge problem. It's all good and well for us who have medical aids and that are, you know, a bit, you know, more middle class in that sense. But I'm always concerned, you know, are there guidelines for dietary or good dietary guidelines for people that have nets that are poor,
Yeah, yeah.
where
So
you're
the
eating
guideline,
really pop, you know, you're eating porridge, cabbage, potatoes, you know.
I definitely think there's work to be done on that. So the guidelines that we're doing at the moment are not for patients; they're for doctors to read.
Okay, yeah.
And dietitians, so more dietitians can be aware of what's the best
The gold
way of
standard.
doing
Yeah.
things.
Mm.
And hopefully that information will be transferred, you know, around the world and go down into the patient population. And of course, patients will read because everyone wants to read anyway, and that's fine. But I think, yeah, we need to do some more work. I am very aware that, you know, when I've done presentations to the US, that lots of people that are poorer are not on the calls as well, and may not ever watch any of the presentations as well. So
Yeah, and I think, you know, well, hopefully we're trying to establish, a lot of our multidisciplinary teams are in teaching hospitals. So at least we know that those patients are getting the benefit of multidisciplinary team discussions. And those professionals are usually very patient-centered. I must say, at Tygerberg and at Grooteskier, the teams there are really, really, and a lot of them are also working in private practice. You know, they also have private practices. So I do think there's a will to do something about it, but it's such a small group of the patient load that is diagnosed with NETs that I think it gets neglected easily.
yeah,
You know, very, very easily. Yeah.
and I think, you know, I could work with you on, you know, diets, because everywhere will have a different access to food and staples and things like that. So
that would be great, because just, you know, even if it's just some basic stuff that when you have had a pancreas removed, or when it's in that part of the digestive system, and that, you know, just very broad basic guidelines and stuff like you said, Andrew, about fluid intake and what you can do for you know, looking at your constipation guidelines, or diarrhea guidelines, because that is a huge thing. But again, adjusted for more poorer. I think, well, linseeds they're expensive, aren't they? Are they linseeds? I'm not sure what they cost.
they're probably not too expensive here, but it depends whether they're grown. You know, do you have to import them?
I must find out about that, because that seems like a very good thing for constipation. So, so we need affordable suggestions that are practical, I think, and I think that would be really great. Yeah. Any other questions, Andrew? Go ahead.
Just a quick one. Just you talk about multidisciplinary teams. You talk about quota skew, and it's encouraging that. But is there any? Are we too small in terms of net sort of patient populations to justify a central net sort of centre? Australia have something like that. When neuroendocrine cancer is specialised at one place, and they bring together, the specialists in all areas, including nutrition and everything else.
Well, I think that's a very good suggestion. I certainly think that in South Africa we do need that, and like centers of excellence.
Yeah, that's right.
Because when I'm busy getting the stuff ready for the website, and I think that I found with our other members the other time that we had, there was somebody from KwaZulu-Natal that gave some names. I followed those up. So there is a small multidisciplinary team there. But the teams that we have in Cape Town are and then there's the ones in Johannesburg. That's also quite good. But I think we need to encourage their collaboration with each other. For us as patients, we need to ask for them to set up a centre of excellence and rather all work together.
Usually, when I had those liver operations done in Donald Gordon, which is a teaching in Johannesburg, the guy who did it was Professor Jean Botha. Now he heads up the liver transplant unit there. They do a lot of liver transplants. But
I emailed him as well.
So I'm very glad. Did he reply?
Oh, yes.
He once told me, when he was in Nebraska, he was there for about 8 years in Nebraska, and they had a complete specialized area that he was part and parcel of, dealing with nets. And it was a wonderful thing. And when I was chatting to him in Joburg once, he said to me, gosh, he wouldn't mind getting back to that again. But he's a busy man. This is the problem. A lot of these chaps are so busy that, he's got a good experience in that area. But,
You gave me his, I think you gave me his, and did you give me his email?
I did. I'll send it up to you again.
No, I think I did email him, but I haven't had a response. Now, I emailed everybody that you sent me.
Yes, I know. And look, I think I also just followed up with him too, and just
that would be great.
And just ask him to be prepared to give a talk, because he had a lot of experience over there, and and he was so knowledgeable when he dealt with me too on my conditions. He knew exactly what was going on. And it's great to have these guys around, and it's great to hear that there are good people down in places like Cape Town. Wonderful.
Yeah, absolutely.
Tara, I'm just absolutely staggered. Look, I'm not a medical person, but the sort of breadth of your knowledge and just what you spoke about tonight is overwhelming. I mean, there's a huge amount of information there, and there's obviously a tremendous need. And I like your idea.
It's very specialized. It's very targeted to the problems that NETS patients have. Yeah,
and this is so delightful. I mean, your average nutritionist, I'm sure, knows all about constipation and diarrhea and steatorrhea and various things like that. But it's just that specialization in NETS is tremendous. How do we do it?
Years of experience. Well, she's going to do some training for us. We're going to try and get her to do some training.
So when you have lots of, we had, I don't know how many patients. I don't work there anymore. I left last year, but at the Royal Free, we have roughly 2,000 patients with various types. So you have to learn very quickly, and there was no one to learn from when I joined, and I had to work it out myself. And we learn from the patients, they feedback, and we know what works. And it's because I saw so many people, and I still see people privately, you just learn.
Could people consult you privately from here as well, Tara?
From everywhere.
Yeah. Okay. Well, that's good. So I can put your email and say you are available for private consultations. They can email you. That's wonderful. I mean, I think people would make use of that. Absolutely.
Thank you. Tara, there's one more question. I'm going for my 3rd PRR treatment next Wednesday. is there any suggestions for diet? Because I find I get very nauseous, especially with the amino steroid
Yeah.
they give me. They've even slowed the drip down like
Yeah.
tremendously because I just throw up so much. I'm very sensitive for that.
Yeah.
Is there any suggestion for diet? So what I've found helped me the last time was fasting. I actually fasted the day before getting my treatment, and it helped. But then even just taking in water, it just comes straight out.
Yeah, well, I would have said the opposite to fasting. Is just because you might feel bad for a few days, that you would need to load your body a bit more with nutrition, and make sure especially that you're hydrated going into it.
Yeah.
Because the effect on the kidneys from that treatment is, is the most likely side effect, or serious side effect anyway. The other thing, there is just a small study, I think, that showed that PRRT used your own antioxidants up during the treatment. And I know there's something around selenium deficiency in going through PRRT. So if you can get selenium measured once you've had the full treatment, then that is something that you could do. But in general, there's no specific foods or anything. Keep well hydrated. So for example, if you know that you're not going to feel very well, not starving yourself is ideal, because there's things like carbohydrate loading, which we do prior to surgery, which helps people get out of hospital quicker because their body is, able to utilize the energy that it's got stored in your muscles and your liver.
Oh.
So,
What about taking antiemetics beforehand? Like, I know that sometimes they would say take a Maxilon, even though you're not nauseous the night before, and kind of line your gut. I don't know whether that's an old wives' tale, but yeah.
Yeah, they should be giving antiemetics.
They give it to you in the drip before.
But even before that, the evening before, you have the drip already.
Okay.
I'm just wondering about that. That was some of the stuff that I've heard over the years.
Okay. It's an
The
idea.
other thing with nausea as well is just obviously avoiding things that make you feel nauseous, but just for the next couple of days once you've had the infusion is just have liquids that you like. So a particular type of soup that you can have just for a few days that's nourishing, but it's not lumpy and going to make you feel sick. Something that goes down, and all your favorite drinks, take things with you to hospital and keep them stored there, just so you can always be drinking and nibbling, or it doesn't have to be healthy. Even you can have your treats and things, minty things, lemony things kind of can help a lot.
Yeah.
The anti-nausea that they give you in the treatment, and I've had it too, and I've been fortunate enough not feeling nauseous afterwards. Is there any possibility they could change it or increase it, or it doesn't work like that?
They can increase your nausea tablets, of course they can.
So when they put in the drip, they put it in the drip, don't they? And whether they could...
Yeah, I don't know about that. Yeah.
No, they did. They put mine in the drip, and then they even gave me the oral one because
as well. Okay.
I had the nausea and the diarrhea, and at the same time, so it was hectic for me. But
Good.
yeah,
Are
even
you quite anxious during the chemotherapy? Do you find yourself being quite anxious?
I think it's just for that specific reason.
Anticipation. Yeah.
For that
So perhaps
reason.
some positive thoughts about it also, to say, this time I'm not going to allow the nausea to, kind of do a bit of mind over matter stuff and try and stay in the moment. And when the nausea idea comes, to say, no, I'm not going to, a little bit, focus on your breathing, nice, slow, deep breaths, those kind of things.
Yeah, I do all of that.
Okay.
When I want to come out,
It just comes like a
No,
bow out of an arrow, or arrow out of a bow. Yeah.
But, yeah, I just thought perhaps there was something else I could try, but yeah, I'll just play it by ear this time again.
Yeah, the other thing actually with nausea, the most probably reliable treatment is ginger in a capsule form. So ginger as supplements, but if you prefer to chew ginger, you can get like the crystallized ginger or ginger stem or something like that, and that can be really good. Or spring onions and things like that. Just random.
I took that with me as well the last time. Took the stem ginger, the dry ginger, the ginger sweets. They get those little bombs. Ginger tea. You're
going to find the cure for that and write a book.
I couldn't smell of it even. Everything was to avoid everything and wait for everything to settle. That's what I found. So I'll see how it goes this time.
Yeah, try that. Yeah, exactly. Tara, thank you so much for your time and effort, and we're going to market your private services here in South Africa. And Andrew, you must find out about names of dietitians that we could invite to our training in the Joburg area, Donald Gordon and so for us.
I'll find out. I'm not based in Joburg myself, but I'm based down in Kloof, which is near Durban.
Okay, but wherever you are, that will be good if you could see if you could get some names for us with who your team works with. That will be good. Thank you for your time, and thank you everybody. I don't know what happened to all our other members, but I'm sure they're going to catch up. I had 2 people that couldn't get online. They had problems with their internet. That's South Africa. And then there was about 3 apologies because of illness.
I think recording they'll watch, definitely, I'm sure.
Yeah, I'm sure they will. And I hope that our website will be up and going by next week. I'll send you a link once it's up and going.
Okay.
Thank you everybody. We haven't decided on a speaker yet. I think Dr. Conradi will be speaking, the surgeon, at our next meeting. So watch the space and I'll keep you informed. Have a good evening, and Tara, thank you very, very much. And I look forward to talking to you more.
Yeah. All right. Take care. Thank you.
Bye, everybody. Bye.
Bye.